welcome again to Conversations in Interventional Cardiology. It's my pleasure to be here with you and a terrific panel. My name is Sahil Parikh from Columbia University in New York City, and I'm an interventional cardiologist here on faculty, and I'm delighted to be joined by two experts in the field of the management of pulmonary embolism for tonight's discussion. I have with me Dr. Jim Horowitz, assistant professor at NYU Langone Medical Center, also here in New York, and Dr. Samir Khandar, just down the road in Philadelphia, associate professor of medicine at the University of Pennsylvania. Jim, without further ado, you want to introduce your manuscript, and then we'll have a little bit of a conversation.
Awesome. Thanks for inviting me to JSCAI to discuss our new publication. It's an analysis of patients with high-risk PE from the U.S. cohort of the FLASH registry who were treated with mechanical thrombectomy. High-risk or massive PE is characterized by hemodynamic instability with early mortality between 25 and 30%, even after reperfusion therapy. And even though guidelines recommend fibrinolytics, this is based on limited data, and fear of complications and complications lead to lower use than you would actually expect in real life. So safer, more effective interventional therapies are needed for patients with this high-risk disease. And mechanical thrombectomy is a promising therapy, but more data is needed in this case. So the FLASH registry is a registry of patients, of almost 800 patients using the FlowTriever mechanical thrombectomy device to remove clots without the need for lytic agents. The device has 16, 20, and 24 French catheters and nitinol discs of different sizes to extract thrombus. And the primary endpoint in FLASH is a major adverse event composite of device-related mortality and major bleeding within 48 hours and intraprocedural device or procedure-related adverse events. So here are your baseline characteristics. In the full cohort, U.S. cohort, there were 63 patients with high-risk PE, and that makes this analysis the largest prospective study of patients with high-risk PE who were treated with mechanical thrombectomy. More than half the patients also had DVT, and about 1/4 were contraindicated to lytic agents, and therefore are contraindicated for the current guideline-directed therapy of lysis. And almost all the patients had centrally located PE. Importantly, these patients presented with signs of hemodynamic compromise, including cardiac arrest with CPR, a vasopressor requirement, sustained hypotension. There were other indicators of severe disease with PE as well. Most of the patients were tachycardic, and most of them had elevated lactate, suggesting end organ hypoperfusion. If you look at the procedural characteristics, there was a median estimated blood loss of about 200 cc's, and that dropped down to 158 with the use of the FlowSaver blood return device. The post-procedure ICU stay was an average of just one night, and 40% of patients had no overnight ICU stay required after the procedure. Here you can see the immediate hemodynamic changes. So the average mean and systolic PA pressures and mean right atrial pressures all decreased significantly after the procedure. In addition, those patients with index less than 2 had improvements in the cardiac index, as you can see on the next to last line below, and PVR dropped as well. Finally, you can see under safety and mortality outcomes, even though patients with high-risk PEs have comorbid conditions and sequelae of cardiogenic shock, there were no MAEs or device-related SAEs at 48 hours here. Most importantly, all 60 of the 63 patients with high-risk PE, they all survived to 48 hours, and there was no all-cause mortalities in any of the 61 patients following a 31-day visit. In the historic context of 25 to 30% of inpatient hospital mortality for this patient population, even after interventional therapy, the lack of all-cause mortalities is noteworthy here. Finally, looking at dyspnea and quality of life, you can see on the left that the dyspnea scores improved dramatically. The red, you can see in the first column, shrinks as you go along to 30 days to less than 15% at 30 days. And then in the middle, if you look at the PE-related quality of life score, you can see an impressive decrease here as well at 30 days. You'll note here that there was no scoring done at time 0 because the patients basically were too sick to stop and do a survey at that time. And looking at readmissions, only less than 10% of patients were readmitted, and all but one of the readmissions were unrelated to PE treatment. So taken as a whole, in the full U.S. cohort of FLASH, all 63 patients with high-risk PE survived to 48 hours. There were no all-cause mortalities in the 61 or 97% of patients who followed up to 30 days. There were no MAEs, no major bleeds, or device-related SAEs through 48 hours. and the patients demonstrated immediate improvements in vital signs and hemodynamics. So for patients with high-risk PE who can be stabilized for mechanical thrombectomy, the procedure has a favorable safety and effectiveness profile and should be considered as a frontline therapy. Thank you.
Thank you, Jim. And let's get right into it. So FLASH was a precursor to subsequent studies, but let's talk about this for a moment. So this is a subgroup of the entire FLASH registry with high-risk PE. And I guess I would ask first, Jim, what is the standard of care in your hospital right now? I mean, you argued that the guideline-directed standard might still be thrombolytic therapy, but I think that that's based on relatively poor, if not insufficient data. What are you guys doing now as a standard of care in your hospital? And Samir, I'll ask you the same question.
I think it depends on which hospital you approach in our, bevy of hospitals. And I think it depends if you asked the question 2 years ago or today. And I think that kind of speaks to where the field is at. The standard of care remains TPA. The dose remains 100 milligrams over 2 hours. And if they're coding, maybe you give 10-20 up front. But as we said in this manuscript, early on, people are terrified to use it because of the risk of intracerebral hemorrhage being 2 to 3%, give or take. And so people use it. Don't use it as the use of it actually has gone down over the past 15 years, despite it being one of the few areas in PE care where there is an answer. Granted, as you implied, there's not a great reason for this answer, but at least there is one answer. So I know I hedged a bit there.
Yeah, so it sort of depends what time of day and where they show up. Samir, what's the status at Penn?
Yeah, I think the standard of care now is really an emergent 24/7 PERT service that's available to help with these patients. Like you alluded to, there's so much variability in how they present and their risk factors and their bleeding risk that years ago, it was really a lot of folks on an island trying to make a decision all by themselves, whether you're in the emergency department or you're on one of the post-surgical floors. In this day and age, now that we have 24/7 PERT coverage and we have a variety of treatment options for them, I think really the standard of care, the first step should be initiating that PERT consult. From there, we can triage. And I think since we've started our PERT team, our use of thrombolytics has actually gone up. There's comfort knowing that the whole team recommends something. At the same time, we now have a variety of mechanical support and a variety of catheter-based treatment options, and occasionally surgery-based treatment options. And at least the PERT team can very quickly evaluate the patient and bring in the appropriate members.
Right. So for us, it's quite similar to what you just described, Samir. It sort of depends on how stable the patient is. And if the patient is stable enough to have a PERT consultation, they get one, in which case you'll have quite a substantial variability ranging from ECMO to emergent surgery all the way to thrombolytics or catheter-directed thrombolytics. And mechanical thrombectomy seems probably the most commonly elected treatment. So to that end, how do we assess these patients? And Jim, just for clarity's sake, in FLASH, what was the official designation for high-risk PE, and how did you dictate that them being stable enough to wait for mechanical thrombectomy, just so that people that are trying to recapitulate these incredibly safe results understand how to do it?
The high-risk PEs were designated by hypotension for 15 minutes or more, requirement for vasopressors or cardiac arrest. So that follows basically the explicit guidelines and kind of the standard language that everybody uses. But I think, as we all know, some patients there are sicker than others. So certainly there's some you can't move, you can't do anything to, and the only choice you have is either ECMO at the bedside or lytics. And there's plenty of patients who are massive or high-risk PEs who you do have a few minutes. Hopefully, if you have a well-oiled machine in your PERT and can get patients up to the lab quickly, that would be a good option for those patients.
Right, and so to sort of look at the safety before we look at the efficacy, which was obviously quite good. One of the big concerns has always been in these patients their hemodynamic stability or lack thereof when you bring them to the lab. But it seemed like in this data set, patients did extremely well and tolerated the procedure really, really well. Why do you think that is, Jim? And was it something about the operators or about the system or about the device?
I'll probably say to some extent all of the above, but I would think that part of the answer is that, hemodynamically, if you make a channel and your PVR goes down somewhat, your RV is probably a bit happier. So it may be that on first pass, if you get a decent amount of clot out and your PVR drops a bit, the RV is a little more stable and gives you time to do more, to do a couple more passes, things that you wouldn't have if the patient just stayed on the gurney, in the ICU getting heparin, perhaps.
Right. And remind me, how many passes on average did these patients receive?
I think that's a question for Samir as the interventionalist.
Yeah.
I mean, in this registry, we didn't define that, but
Samir, you're intimately involved in the FLASH registry. What do you think, or what's your gut tell you?
With these really high-risk patients, which you alluded to, it really is a race for the procedure to getting thrombus out. And in these cases, usually we'll skip the initial pulmonary angiograms. We know where the clot is, and you just want to get into the main PAs as fast as possible. I usually treat the right and then go into the left. I find that a little bit easier. And typically with these patients, the clot is just embolized. It's still very large, oftentimes fairly central. And this clot's not adherent to the wall. These patients haven't been on heparin for a few days. And so it usually comes out very quickly in very large pieces. And so this really is a race. It's a matter of just being proficient at the procedure, getting into the pulmonary artery as quickly as possible.
Right.
It's amazing. Once you do usually 1 to 2 aspirations that are successful, that things really settle down very quickly.
Yeah, that's what I was driving at. I think that the collective experience seems to be that perfect is the enemy of good enough, and that these patients are quite frequently stabilized with very few passes, which I think is a testament to the ability of this technique to really change the pulmonary vascular resistance relatively quickly and unload the RV, as you pointed out, Jim. So that's interesting, and this sets the table for additional data sets. I think to contextualize this, I think we were going to talk a little bit about FLAME, and if we have opportunity, we'd like to sort of see how this compares and contrasts to FLAME, because I think that they're quite similar, aren't they?
Yes. So I think recognition of this subsets and how well they did was led to the earliest discussions to look at a registry of just massive PE patients. That was a pretty intense couple of first conversations to go after patients who were that ill. As you said, they can decompensate so quickly, but given this subset that we were kind of seeing as that it was being collected, FLAME was sort of born. And the idea with FLAME was it basically is 2 paired registries. So it's a registry of patients with high-risk PE who get flow retriever mechanical thrombectomy. And there's also a second pair registry of patients who did not get mechanical thrombectomy, who got standard of care at their institution. It could be heparin, it could be another device, it could be ECMO, it could be anything else. And that was the context arm. And then it was also compared to basically historical meta-analysis of patient outcomes who were similarly sick. So the goal here was not to compare directly to the context arm, but more to the historical meta-analysis controls, which sort of set the baseline for the mortality that we expected.
So, Jim, thanks for the summary of the genesis of FLAME. So, Samir, again, as one of the investigators, do you want to sort of tell us what the results look like and where the puck is now moving in the space?
Fortunately, it's an exciting time in the field of high-risk PE that in a short period of time, we've been able to put together a much deeper understanding as well as several studies. It took some registry-based studies to get comfortable with the devices, with the concept of mechanical thrombectomy, and to move away from thrombolytics. and really set the groundwork for Flame, but we weren't ready just yet for a true randomized clinical trial. Shock patients are so difficult, and there's such a wide spectrum within that. And we've dealt with this and the cardiogenic shock from acute MI side as well, that it's just very difficult to develop the perfect randomized trial. And therefore, this concept really was, let's develop Flame, which is 2 registries to follow all high-risk patients, to really capture all of these patients to get a deeper understanding in 2020 to 23 where we are at now. And while there are 2 cohorts, they really were not designed to be a comparison of each other. Again, this was not a randomized study of mechanical thrombectomy versus medical therapy or standard of care, but to just really understand where are we in this day and age. And what it showed us was mortality still is high in high-risk pulmonary embolism, that mechanical thrombectomy really should be considered as a treatment option that's here to stay and that can really be offered to patients. But we still have work to do. We still have work to do to better understand which patients are best treated with mechanical thrombectomy versus pharmacotherapy, and which patients may need mechanical support. And I think these steps and these studies really just raise the awareness, and now have really brought to the forefront this concept that there are treatment options beyond just thrombolytics.
And just for the audience, for context, the order of magnitude of the mortalities, if I'm not mistaken, is in the 40% plus range for those with standard of care in most contemporary registries. But what did you guys see in Flame for the mechanical thrombectomy group?
It was around 2%.
Yeah, so it's like a extraordinarily different sort of number, and whereas there's been some criticism about whether this population was as sick as what we've seen historically, it certainly is at best, thought-provoking, and certainly should be a hypothesis generating for future studies. I think that for those of us in the field, it certainly stands as a landmark that there are possibilities for us to bend the mortality curve. We've been struggling in cardiogenic shock with acute MI for the last 4 decades to bend that curve, and have not been able to, despite mechanical circulatory support and aggressive primary PCI, change that very much until recently. And it seems that this may be the same in pulmonary embolism. So it's an exciting time to be part of this field. It's a really exciting time to be a contributor. Lastly, I would ask you both to perhaps speculate, which I know is unfair, but I'm going to ask anyway. What do you think is the sweet spot for these devices, and how should operators that are interested in building a PERT program do it?
I think with these devices, like any training curve, you want to start with the patients that are more on the intermediate risk, where you have some time to work through the steps sequentially, as opposed to the massive PE, where really you're moving as fast as possible. So, I think trying to build up a skill set to understand the pulmonary architecture, the vasculature, understand how these devices work, and the idea behind thrombectomy, what's enough. Also, the hemodynamics and the response is the way to go. And as you get more facile with that, then start to push to patients that are higher and higher risk.
And I would add, it sort of goes along with the power of PERT essentially across the board. Samir mentioned that with the growth of their PERT, the use of thrombolytics went up. There's data from other centers that the time from diagnosis to initial anticoagulation goes down with the PERT. So on when you first get your PERT going, you start getting better at fundamentals. So the basic stuff that we all should be doing can get faster and faster, more efficient. And then when your operators start doing cases, as Samir said, they get more and more facile and get better at that. And so the signal that we saw here was exactly the progression of that, which is, geez, if your team gets good at the technique and we can get patients there faster, aka like STEMI, then lo and behold, look what happens. And we see this signal, and that's became the genesis of Flame. And as you guys implied, no, it's not a randomized trial. No, it's not the end of the discussion. but it's a really interesting signal that we could really change the trajectory of this disease in a way that we haven't in a lot of other diseases, and certainly not in PE. We haven't found that STEMI equivalent yet in the submassive territory, and we really haven't moved the needle yet on massive. So hopefully this is the start of both, with this and other trials in the field, with 4 and 5 RCTs ongoing now.
Yeah, and I think that's the exciting part, is that not only are we endowed with all kinds of new technologies, but we're finally getting real, level 1 data to inform our decisions. So I want to thank you both for taking the time to speak to me tonight, and I think our audience is going to dig into the papers and start looking at the data for themselves. Again, I want to thank everybody out there for listening, and we look forward to seeing you back for more conversations in interventional cardiology. The manuscript that Jim talked about is published in SCAI very recently, and we look forward to hearing your comments. Thanks very much, everybody, and we look forward to seeing you soon.